Okay. Hello, everybody. Welcome to this webinar. This is the 8th webinar of the Anesthesia and Intensive Care Schools of Milano Bicocca, Milano San Raffaele, and Torino. It's a pleasure to be here, and it's a real pleasure and honor to introduce Professor Devereaux, who is a Canadian cardiologist. He's a professor at the Department of Medicine at McMaster University, Hamilton, Ontario, Canada, and he specializes in perioperative care. So how to optimize the perioperative management of patients and on fragile and specifically patients undergoing non-cardiac surgery. He has done several groundbreaking studies in the field of perioperative care, large multi-center international randomized controlled trials, investigating both drugs such as beta blockers, tranexamic acids, aspirin, and many more, but also procedures and timing of surgery, like the hip attack, which is currently ongoing. So it's a pleasure to have him here and to hear about how to optimize perioperative care. Two brief comments on how this will work. So you can ask questions, and we ask you to do so in the chat box. So please ask whatever question you have. Dr. Francesca Mulazzani, who is a colleague here from Milan, from the Guardia Hospital, and a former research fellow of Professor Devereaux, will collect the questions and ask them to Professor Devereaux at the end of the presentation. Without losing time, of course, I'm pleased to see also the other panelists, Dr. Turi from San Raffaele, Dr. Collino from Torino, and Professor Fumagalli from Milano Bicocca. So with that said, thank you again for being here. I would ask you to share your screen and start the presentation, please.
Okay, great. Well, thank you very much for the opportunity to be here. Just got to make sure I have the right screen. Screen here. Can you see my screen now?
Yes, perfectly.
Okay, great. Okay, thank you very much for the opportunity to present here today. As part of our institutional policy, we're expected to put up our disclosures at the start of our talks. Based on study questions, I've originated grants. I've received grants from many different companies that are listed here. We're always looking for more too. The goals of the presentation are I want to discuss 6 areas of perioperative research that have been some of the main focuses in our group, not all of them, but some of the main ones. So prevention of perioperative vascular complications, the concept of myocardial injury after non-cardiac surgery MINS, preoperative risk estimation, perioperative overt and covert stroke, the timing of surgery, and where we spend the dominance of our time right now is on virtual care and remote automated monitoring technologies, and then a bit about the future. So my thesis is going to be is that it takes a community to inspire, mentor, and enable a successful academic clinician. And I've been very fortunate to have lots of support to allow me to have the career that I've had. And it's really important that we support all our young colleagues like Francesca as an example, and many others that exist, I'm sure, in your institution. So in terms of inspiration, I come from the best part of Canada. This is Cape Breton Island. It's on the east coast. It's from the island. It's in Nova Scotia, and we're on the most remote part of this province. And I was growing up, I read a book. It's called Memoirs of the Cape Breton Doctor, and I grew up in a very rural setting. And in this setting, in this book, Dr. McMillan would talk about, doing an appendectomy on someone's kitchen table, doing a delivery in their house, and a doctor in these rural communities has a very different relationship than a doctor that exists in Hamilton, as an example, in a bigger city. And my goal was always to become a doctor and go back to Cape Breton Island and be a real doctor. This is Dr. David Sackett. David Sackett was sort of the godfather of clinical epidemiology. And when I came to McMaster, I had no intention of being a researcher. That was the furthest thing from my mind. It was really to become a clinician and go back to Cape Breton. I had the very good fortune that Dave would be my assigned student mentor, and he would expose me to a world of research which I had never considered, but would end up being a very good um, sort of structure for what made me very interested. Because what I would realize in very quickly in medical school is that obviously, if I went back to Cape Breton Island as a clinician, maybe I could affect the lives of, 15, 20,000 people, maybe in a very busy, long career. But what Dave made me realize was that through research, there was potential to affect millions of people's care all over the world if you're willing to invest in doing big international clinical research. Dave was a great mentor, and he would have outstanding speakers come all the time. And one of the speakers he had come was Lee Goldman. And whenever Dave would have speakers in, he would invite me to come out to dinner, meet these people. And I met Lee, and he was a very inspirational guy. Lee obviously did some of the initial work in terms of establishing the first risk index for perioperative cardiovascular risk. And then this is Alan Deskey. And I then in medical school went and did an elective with Alan, who's in Toronto, and Alan had developed the Deskey cardiovascular risk index for perioperative care. And Alan is a very hilarious guy. He's quite a character. And from this exposure, what I realized at the end of this rotation is that surgery was very common and that it was and it was primarily going to grow in the elderly. Periop was a very fascinating laboratory because it was associated with hemodynamic compromise, hypercoagulability, inflammation, and sympathetic stimulation, which were all factors that could predispose to cardiovascular complications. And what I also realized at this time, this was like 1993, that we actually knew little about how to really accurately predict, identify, prevent, and manage these events. And so even though I was going off into cardiology, one of my other mentors, Salim Youssef, who I'll mention in a moment, really had encouraged me to say, like, if you find a desert, you can build an oasis and really help advance areas in an area where there's not been a lot of advancement. And that really appealed to me. What I've learned is that inspiration comes from our role models, our patients, and our research. And I'll share examples of that. So if we look at the prevention of perioperative vascular complications, in the 1990s, there was 2 small randomized controlled trials with a total sample size of 312 patients. They had methodological limitations, but they suggested very large perioperative beta blocker effects to prevent major cardiovascular events and death in people having non-cardiac surgery. Guidelines recommended to give perioperative beta blockers based on these 2 trials and physiological rationale. And in many places, like in America, hospitals were actually financially penalized if they did not give beta blockers to Medicare patients having major non-cardiac surgery. We then undertook the POISE-1 trial. This was our first big trial in perioperative care to test whether or not beta blockers were truly beneficial in people having non-cardiac surgery. We had enormous resistance in terms of doing this trial because so many people viewed that beta blockers were unequivocally beneficial and that there was no risk associated with them. Our position was we thought it was very encouraging that beta blockers were potentially beneficial, but it was far from clear whether or not they were actually truly safe, and we really needed a big trial to know the true effects. So in POISE-1, which was a blinded randomized controlled trial, we included patients who were age 45 or greater having non-cardiac surgery and had or were at risk of atherosclerotic disease. We randomized them to metoprolol CR, which is a long-acting formulation, or placebo. They started the drugs 2 to 4 hours before surgery and continued for 30 days. The main outcome was a 30-day composite of cardiovascular death, non-fatal MI, and non-fatal cardiac arrest. In this trial, what we demonstrated is that beta blockers reduced the primary outcome. There was 244 patients in the metoprolol group who suffered the primary endpoint, that's 5.8%, whereas in the placebo group, there was 290 patients who suffered the primary outcome, that is 6.9%. This is a result that is statistically significant. However, we learned many lessons from POISE-1, and one was how composite endpoints can frequently be very misleading. The reality was it would be erroneous to assume that beta blockers were preventing cardiovascular death and non-fatal cardiac arrest. What beta blockers were unequivocally doing was they were reducing the risk of myocardial infarction. So if you look at non-fatal myocardial infarction or all myocardial infarctions, there is overwhelming evidence, and POISE-1 dominates it, but the evidence is very clear. Beta blockers, if started just prior to surgery and continued throughout the perioperative period, will reduce the risk of myocardial infarction by about 30%. Result that is highly statistically significant. There's not much ambiguity about that effect. However, what we would also discover was that mortality, in fact, went up with beta blockers. So 129 patients in the metoprolol group, 97 in the placebo group would die in the first 30 days, a result that was statistically significant, increasing the risk by about a third. And also we demonstrated that the risk of stroke would go up. 41 strokes in the metoprolol group, 19 in the placebo group, a doubling of the risk, a result that's highly statistically significant. I also want to emphasize a point. These strokes were devastating strokes. A third of the patients who would have a stroke will be dead within 30 days. Now, those who survived, over 55% will be incapacitated or needing help with everyday activities. These were very devastating strokes. Trying to understand how did this result happen, we looked at the issue of hemodynamics. So one of the errors I think that we had in designing POISE-1 was, as cardiologists and the anesthesia people in our group, I don't think we truly appreciated that on surgical floors, what would happen around hemodynamic abnormalities. Obviously in the OR, anesthetists are probably the most adept people in terms of identifying and quickly rectifying hemodynamic compromise. And certainly as cardiologists in the CCU, we feel very comfortable to recognize and acutely manage hypotension. But that would not be the case on surgical floors. And if we look at clinically significant hypotension, so that is a systolic blood pressure less than 90, that results in symptoms and people needing to intervene, that occurred on the surgical floor in 15% of the patients in the metoprolol group and just under 10% in the placebo group. This is a 50% relative increase, a result that was highly significant. And what we demonstrated is that this clinically important hypotension had a big impact. So if we look at all the complications that happen after surgery, clinically significant hypotension had, in adjusting for baseline and other clinical variables, a 5-fold increase in the probability of death in 30 days. And if you look at the attributable fraction, that is the proportion of overall deaths potentially explained by that complication, it was 37% of them. It didn't matter why you became hypotensive. If you became hypotensive because you were septic, you had heart failure, you were bleeding, whatever it was, if you were on a beta blocker, you were in serious trouble, especially if you were on a surgical floor. And the same was also the finding for stroke. It increased the risk of stroke. It doubled the risk. So insights from POISE-1 was that perioperative beta blockers had the potential for benefit, MI reduction, potential for harm, increased risk of stroke and death. It highlighted the importance of clinically important hypotension and also the need for large randomized controlled trials in the perioperative setting. It is an inconvenient truth, but I can't emphasize this point enough. If we actually really want to understand the effects of interventions in the perioperative setting, you need large clinical trials. And we also identified that we need to find a means to safely control the sympathetic system. We should not negate there is a clear benefit to beta blockers. The issue is how to do it safely or how to control the sympathetic system through another means. This is Gordon Guyatt on the left and Salim Youssef on the right. So I did my PhD training under them. Gordon was the one who coined the term evidence-based medicine and really led the development of the movement of evidence-based medicine. And Salim Youssef would probably be, in fairness, the most prolific cardiovascular researcher in terms of large international studies, both randomized controlled trials and observational studies in the world. And I was very fortunate to have them, and they were outstanding mentors, still remain good, outstanding mentors to me. After beta blockers, we made a decision to next consider whether or not clonidine might be the pathway to actually safely control the sympathetic system in the perioperative setting. The reason we did this was we did meta-analysis work and pilot work, which suggested that clonidine, in contrast to all the beta blocker trials, had less clinically significant hypotension perioperatively. And we knew that hypotension was likely the Achilles heel that would get people into trouble. So we thought maybe this would be the pathway to do it. So in POISE-2, we randomized just over 10,000 patients undergoing non-cardiac surgery who had known vascular disease or risk factors. And what we demonstrated was the 30-day mortality with clonidine was 1.3%, and the placebo group was 1.3%. So in contrast to the beta blocker story, we did get what we expected here. We didn't see an increased risk of death. When it came, though, to non-fatal myocardial infarction, we didn't see a reduction with clonidine. There was no effect with clonidine. So when you look at the results of POISE-1 and POISE-2, they're discordant in terms of MI and mortality. Clonidine, as it happened, had substantially less heart rate effect compared to metoprolol, which may in fact be why we did not see the reduction in myocardial infarction compared to what we saw with beta blockers. Clonidine had less hypotension than metoprolol, and this likely explains why, in fact, we did not see an excess of death or stroke with clonidine, but we did with beta blockers. These data highlight that the ideal perioperative sympathetic control may require decreasing the heart rate to prevent MI, but avoiding hypotension to prevent death, or to avoid death or stroke. Beyond the sympathetic system, we were very interested in the coagulation system. And we knew, and we know from studies I'll show you in a moment, that some of the perioperative MIs are due to thrombotic events. So we wanted to test what will be the effect of aspirin perioperatively. So again, in POISE-2, which had 10,000 patients, we randomized patients to either receive aspirin perioperatively or placebo. We had two groups, that is, patients who were naive to aspirin, weren't receiving aspirin, and patients who were on chronic aspirin. They had to stop aspirin at least 3 days before surgery, and then were randomized to start aspirin on the day of surgery or placebo. For the overall group, there was no difference in terms of death or MI in aspirin versus placebo. The result was the same for people who were taking aspirin chronically or people who were naive to aspirin. There was, however, unequivocal increase in the risk of major and life-threatening bleeding, the hazard ratio being 1.23, a result that is statistically significant. I will put forward to you, and I'll show you in a moment, more data to support this. It is likely, what we didn't appreciate as cardiovascular researchers is that I think we really underappreciated the importance of bleeding perioperatively. I think this is a very common problem in the perioperative setting. I want to emphasize a point. Patients don't have to bleed to death for bleeding to be an enormous pathway resulting in death. Once patients bleed, a whole cascade of events happens that can get the patient into trouble. So as an example, if a patient has hemodynamically significant coronary disease and they bleed, just due to supply-demand mismatch, they may in fact have myocardial infarction. And I suspect why we saw no effect on myocardial infarction is that likely we caused some myocardial infarction through supply-demand mismatch. And at the same time, we didn't see an increase in the risk of myocardial infarction because we likely were preventing some myocardial infarctions that were due to thrombosis, and you end up with this neutral effect. But unequivocally, you are increasing the risk of bleeding, and that has, as I said, many deleterious effects. There is one group for which this is an exception, and this is the group that has a prior history of coronary artery revascularization with PCI, percutaneous approach. So we had a subgroup analysis paper that we published in the Annals of Internal Medicine. And if you look at the patients who had a prior PCI, what you see is when you're looking at death or MI in the aspirin group, 14 patients, and in the placebo group, 27 patients, hazard ratio 0.50, 50% reduction, a result that is statistically significant. The interaction p-value is significant, saying that the results are different for patients who don't have a PCI versus those that do. Now, it is only, 500-ish patients that are in this analysis. However, I would put forward to you that it's likely that this is a true finding. And the reason that I say to you that it's likely a true finding, in contrast to most patients having non-cardiac surgery, patients who have a prior stent are much more vulnerable to thrombotic MI. Hence, aspirin now becomes beneficial because the dominance of MIs end up being thrombotic, whereas in the non-stent patient, it is more probable that supply-demand mismatch will be the cause of MI, and there we end up with a neutral effect in terms of preventing MI. So basically, based upon this, our recommendation is to hold aspirin or not give aspirin to the vast majority of people having surgery, except those that have had a prior PCI. Based on this work and work from the vision study that we did, we now would truly appreciate that bleeding was a much bigger part of the issue and problem in the perioperative setting. So in POISE-3, we then tested tranexamic acid. So in POISE-3, we randomized just over 9,500 patients in 114 centers in 22 countries, and we had 99.9% complete the 30-day follow-up. Looking at the primary efficacy endpoint, which is a composite of bleeding endpoint, it occurred in 433 patients in the TXA group and 561 in the placebo group. That's 9% versus 11.7%. It has a hazard ratio of 0.76, a result that is highly, highly statistically significant. So I think there is no ambiguity. TXA in general, given to our patients having in-hospital major non-cardiac surgery, lowers the risk substantially of patients having a major life-threatening or critical organ bleeding. We also wanted to know what the safety, and so to make the sample size large enough that we could actually look at subgroups, we created a safety endpoint. And the issue in safety is we created a non-inferiority margin. We took advantage, and how people choose non-inferiority margins, there's lots of issues with how it's chosen, but we were able to basically select one that would be very small that would allow us to then increase the sample size. So again, we'd be able to look at the efficacy endpoints and all the subgroups. What we saw is that if we look at all vascular complications that could be thrombotic, we had 649 in the TXA group. We had 639 in the placebo group. So just under 1,300 potential thrombotic events, absolute difference between the two groups of only 10. Hazard ratio of 1.023, a result that is definitely not statistically significant. P-value 0.04. It didn't meet our non-inferiority margin, which we set very low, but a meta-analysis updated after POISE-3 even surpassed our very low non-inferiority margin. I think it is safe to say that when you look at the overwhelming data on this, there's a very low probability that TXA would increase the risk of thrombotic events, but an unequivocal benefit in terms of preventing life-threatening critical organ bleeding and major bleeding. If we then look at all other sort of categorizations of bleeding, so BIMS, which is bleeding independently associated with mortality after surgery. We look at major bleeding, ISTH major bleeding, transfusion of 2 or more units, transfusion of 2 to 4 units. Every one of these outcomes are highly statistically significantly reduced with TXA, and reductions of basically 25% to almost 30%. So insights from POISE-3 is that among patients undergoing non-cardiac surgery, TXA reduced the risk of a composite of life-threatening major and critical organ bleeding. Although TXA had no significant effect on major vascular complications, our non-inferiority margin was not established in the main paper. However, our results demonstrated a 95.6% probability that the primary safety endpoint hazard ratio was below our non-inferiority margin. And as I mentioned, in an updated meta-analysis after this, it has now been demonstrated to be below that even very low non-inferiority margin. This is Maura Marcucci, who is a colleague of ours. She's now back in Milan. She had been many years in Hamilton, and she ran the factorial design in POISE-3 that dealt with hemodynamics. We published these results in the Annals of Internal Medicine, and we were exploring in the patients in POISE-3 who were taking an antihypertensive, whether or not a hypotensive versus hypertensive avoidance strategy will be more beneficial. Patients randomized to the hypotension avoidance strategy. During surgery, we asked the anesthetist to target a MAP of 80 or greater. And before surgery and for the first 2 days after surgery, ACEs and ARBs were to be held, and patients only receive their other antihypertensives based on an algorithm where you first, at a minimum, had to have a systolic blood pressure of 130 if you were to get a beta blocker, and then you had to be above 155 in order to get any other antihypertensives. In the hypertension avoidance strategy, we asked the anesthetist to target a MAP of 60 or greater, and before surgery and for the first 2 days after surgery, all antihypertensives were continued, including ACEs and ARBs. The results was that 14% of patients in both groups had a major vascular complication within 30 days of surgery. There was no between group significant difference, highlighting that it is both reasonable to withhold and it's also reasonable to give antihypertensives in the perioperative setting if patients are taking them chronically. We saw very small mean differences in the blood pressure with less than 1.17, and very small differences in heart rate with less than 1.4 beats per minute between the two groups. This likely explains why, again, there was no difference in terms of cardiovascular outcomes between these groups. We also saw no dose effect between compliance and effect of hemodynamics and the vascular outcomes. Study significance is that POISE-3 hemodynamic study informs a question that commonly confronts physicians regarding taking care of patients undergoing surgery. Targeting a MAP of greater than 80 or greater than 60 appears to be safe for the vast majority of patients. You do not need a target greater than 80, but it's also reasonable to target higher. At the same time, withholding ACEs and ARBs and following an algorithm versus just giving all the antihypertensives, both approaches are safe. That being said, it's irrational not to look at each individual patient. If your patient undergoing surgery is on the hypotensive side, then I would definitely hold their antihypertensives. At the same time, if the patient has a robust blood pressure or they're hypertensive, I would definitely give the antihypertensive. So POISE-3 shows on average holding or giving these antihypertensives is safe, but at an individual patient level, you should take into account patient's hemodynamics. I now want to switch to discussions of the concept of myocardial injury after non-cardiac surgery, MINS. I'd ask you, who said the following? The diagnosis of coronary artery occlusion following an operation is frequently difficult, since the very severe pain ordinarily associated with this condition may be absent. It was present in only 40% of the cases. This disparity may be accounted for in part by the liberal use of narcotics and sedatives after operations. Does anyone want to venture a guess of who made this statement? You were a shy group. Well, I hope you would have guessed that it was our group or that it said this, but the reality is that this statement comes from an article published in JAMA in the year 1938. So Master and colleagues made an incredibly astute observation before we had troponins, before we even had CK. Even getting ECGs in 1938 was a very complicated thing. But they had all these patients who had serious MIs, in fact, died postoperatively, but they were making the observation that only 40% of them had chest pain or any ischemic symptoms. That was a really astute observation that basically got lost in the annals of the history of medicine. We would later discover this, 8 decades later, but the original observation was made a long time ago about how surgery creates a vulnerable environment where myocardial infarction can be missed but have devastating consequences. The case that led for us developing the concept of MINS comes from 20 years ago. It was one of the patients that I saw in the POISE-1 trial. So this was it was very early on in the trial. It was a 65-year-old man who had no known coronary artery disease, but get in the trial because of risk factors. This guy was a type A personality. He was a business executive, and he ended up having a hip done. He had an elective hip procedure. And on postoperative day 2, because he was in the trial, we were measuring troponins. And I got a call. I was on call in the cardiac care unit. I had a call from my study nurse saying that this patient's troponin was dramatically elevated. I asked if he had any symptoms. She said no. I said, get an ECG. And I said I'd be down to see him as soon as I was finished rounding in the CCU. When I came and saw this patient, his troponin was dramatically elevated. His ECG showed deep inverted T waves across his anterior leads, looked like a Welland pattern. But it was true, this patient had no symptoms. I told this patient he had or was having a heart attack. I was going to take him to CCU, and based upon how things went in the next 24 hours, would determine what further tests and interventions I may need to do. This patient was instantly, this was pre-gray hair. So this patient, I think, thought, that he sort of wondered if I went to medical school, and said, I can't be having a heart attack. I've never had chest pain in my life. I've been fine. And as I looked through this patient's chart, what I realized is this patient was getting substantial doses of narcotics. And one thing that I had appreciated when I first started doing my internal medicine training just before cardiology training was just at the advent when we were switching from or doing the trials on thrombolytics versus direct PCI for acute MI. And one of the things I was always very struck by when we'd be managing patients with acute MI before we would go directly to the cath lab is that if you'd manage patients with thrombolytics, oftentimes you'd be giving nitrates and pain may get a little better, but it would usually come back and you couldn't get rid of it with just nitro. But if you gave patients narcotics, pain would disappear. And everyone would worry that we were simply masking actual ischemia and patients were still having infarcts. And so with this patient, I then realized would end up having a very large infarct, that we are vulnerable in the perioperative period because most infarcts happen in the first 36 hours after surgery, where a lot of patients are receiving narcotics that can easily result in the masking of ischemic symptoms. And these events can actually be a big event that could have a devastating consequence. This is what led me to design the the vision study, and this ultimately led to us developing the concept of MINS. So in vision, one of our primary objectives was to inform the relationship between perioperative troponin measurements and 30-day mortality. Vision was a prospective cohort study of a representative sample of over 40,000 patients undergoing non-cardiac surgery. We specifically were taking people having elective, urgent, and urgent emergent surgery, people having day surgery, night surgery, people having weekday and weekend surgery. We included patients age 45 or greater. It just had to be inpatient non-cardiac surgery. We had 28 centers in 14 countries from all over the world. We measured troponins 6 to 12 hours after surgery and daily for 3 days. And we determined if there were peak troponin T thresholds during the first 3 days after surgery that were independently altered the probability of 30-day mortality. And we did this through using iterative Cox models. There's very fascinating issues, which I'd be happy to discuss in the discussion section, about how one determines the actual right thresholds for biomarkers. We all accept what the lab tells us is an abnormal threshold, but a lot of times, like what the lab would tell you with troponin is that the 99th percentile of the healthy population is what's abnormal. But that makes an assumption that nature knew we would choose the 99th percentile, which is an incredible leap of faith to think that nature would know we would choose that. We wanted to have large enough studies where we wouldn't have to depend on guessing what was the threshold, but in fact, we get a lot of advanced statistics to demonstrate where, in fact, risk really changed with the biomarker. This shows you the results in the first 15,000 patients in Vision, where we were measuring the non-high sensitive troponin T. And what you see is this very clear dose response to 30-day mortality based upon the non-high sensitive troponin T. Now, labs would tell you 0.04 was abnormal. What we would demonstrate is even at 0.02, your risk of death rose from 1% to 4%. And at 0.03, your risk was already up to 9%. And at 0.3 or greater, your risk was now up to 16%. So it shows this very striking dose response. As troponin goes up, your probability of death at 30 days is substantially rising. And these are not large troponin elevations. We then wanted to explore, should we stick with the definition of myocardial infarction? Myocardial infarction, based on the universal definition of MI, requires troponin elevation with either ischemic symptoms or ischemic ECG changes. we knew in the perioperative setting, most people weren't going to have symptoms. We also knew there was a big vulnerability that you might miss the ECG changes. And the reason being is that if you're measuring troponin, and let's imagine that you have a patient today who has a large bowel resection, and tomorrow morning you measure troponin and it's normal at 8 a.m. But at 9 a.m., the patient starts to have myocardial ischemia, which ultimately ends up being myocardial infarction. But the patient is getting narcotics and the patient doesn't experience any pain. So no one repeats the troponin until the next morning. The next morning, the troponin is elevated. Now at 9 a.m. the day before, the ECG was abnormal. But the next morning, the ECG, it's not normal, but it's not clearly abnormal to show ischemia. So because we knew we were vulnerable to miss this, we wanted to explore, envision the patients who had elevated troponins, and envision, because we didn't know ahead of time what would be the threshold for abnormal, we used the lab threshold of 0.04, and we mandated that if patients had an elevated troponin of 0.04 or greater, they had to be assessed for ischemic symptoms, and they needed to get ECGs done. What we demonstrated first was we looked at all the elevated troponins. If there was evidence of a non-ischemic etiology, that is sepsis, rapid atrial fibrillation, pulmonary embolism, chronically elevated troponin, those cases were removed. We wanted to come back to a belief it was ischemic. And now what we did was we looked to see, of the patients who had an elevated, believed to be ischemic troponin elevation, did the patient need a clinical feature of ischemia, that is ischemic symptoms or ischemic ECG changes? When patients had a clinical feature of ischemia, the adjusted probability of death at 30 days was about a 5-fold increase. But importantly, when patients had an elevated troponin and no ischemic symptoms and no ischemic ECG changes, it still resulted in over a 3-fold increase in the probability of death at 30 days. In other words, just because your patients don't have ischemic symptoms or identified ischemic ECG changes, it doesn't mean it's a benign event. And so based on this, we then defined that MINS would basically be if you either met the definition of MI, that is troponin elevation with ischemic feature, or you had an isolated ischemic troponin elevation that occurred in the first 30 days after surgery. MINS did not include patients that had non-ischemic etiologies for the troponin elevation. That is sepsis, rapid atrial fibrillation, pulmonary embolism, chronically elevated troponins. We then next went on to look at the high sensitive troponin T, because we knew that's where the world was going to move to, the high sensitive assays. And here we studied just under 23,000 patients. And again, we demonstrated this very clear dose response. As your troponin went up, your probability of death went up. So as an example, if your troponin after non-cardiac surgery is 1,000 or greater, your probability of death at 30 days is 30%. I have seen, because our program in Hamilton, we measure troponins on all patients age 65 or greater, known vascular disease having surgery. I've seen many patients with troponins over 1,000 who had no symptoms. And if we weren't measuring troponins, we never would have detected it. And again, those patients have a 30% probability of death at 30 days. So this raised the question, should you measure troponins perioperatively? So to first back up a step, even if you say you're not sure about MINS, which I would strongly encourage you to recognize as a really important event, I don't ever hear anyone debate whether or not a myocardial infarction is important. In POISE 1, 415 patients had a myocardial infarction. 2/3 of those myocardial infarctions were asymptomatic, that is, troponin elevation with ischemic ECG changes, like the patient I told you about that led to us doing vision and developing the concept of MINS. In POISE 1, the symptomatic MIs and the asymptomatic MIs had the exact same impact in terms of 30-day mortality, over a 4-fold increase. So again, if you don't measure troponins, you will miss 2/3 of the myocardial infarctions that occur perioperatively. But as I already made the case to you, the story is much bigger than myocardial infarction. You really want to get all of the ischemic myocardial injuries. And in vision, 93% of the MINS events happen without ischemic symptoms, and those events would have been missed if we didn't measure troponins. And again, the asymptomatic ischemic myocardial injuries have a 3-fold increase in 30-day mortality. Which patients should you measure perioperative troponins in? So you obviously want to target groups that become practical and simple to get into clinical practice. And so we've published cost consequence analyses. So basically, if you measure troponins for the first 3 days after surgery in patients age 65 or greater, or patients who have a history of atherosclerotic disease, that is cerebral, coronary, or peripheral atherosclerotic disease, the cost to avoid missing a MINS event is less than tenfold the cost of screening to avoid missing breast cancer, cervical cancer, or prostate cancer. This is not to advocate not to screen for cancer, but economic analysis, when you give people the actual economics, frequently is difficult for people to comprehend because they don't have a context of what we're currently doing. But just to make the case that screening for cancers is tenfold more expensive than screening for MINS, but there is a profound difference in screening for breast, endometrial, or prostate cancer. When you screen people for cancer, you're typically identifying cancers that put people at risk of dying from the cancer 5 years from now. When we screen for MINS, these people are at risk of dying in the coming weeks. So from a temporal point of view, these events have much more immediate impact to patients. Guidelines now around the world have recommended to measure troponins in at-risk patients undergoing non-cardiac surgery. This includes the Canadian Cardiovascular Society guidelines, the Brazilian Society of Cardiology guidelines, the fourth universal definition of MI, up to date. Through the AHA, there's now been a consensus scientific statement on MINS, which recommended to measure troponins perioperatively. And most recently, the ESC, European Society of Cardiology 2022 guidelines recommended to measure troponins perioperatively in people over 65 or known vascular disease. We wanted to have further insights into the etiology of perioperative MI and MINS. And so we undertook the Optimus study. We had 30 patients who had a perioperative MI, and we took 30 patients who had a non-operative MI. And we took these patients to the cath lab and we used ocular coherence tomography, OCT. I'll show you this in a moment. It's our most advanced imaging in cardiology. 1 in 8 perioperative MIs demonstrated acute thrombus, which means that 7 in 8 were supply-demand mismatch. The culprit lesion, however, was the exact same between the non-operative and the operative MIs. 60% of patients demonstrated a fibroatheromatous plaque in the perioperative MIs that is very vulnerable to recurrent events. Most people with MINS don't die of the initial event. They die of the recurrent event that happens in the next weeks to months after the initial event. Importantly, symptoms and the degree of troponin elevation and ECG changes did not differentiate whether or not it was a thrombotic versus a non-thrombotic perioperative MI. The only exception being if it's ST elevation. It's ST elevation that substantially increased the probability it is a thrombotic MI, but you can't tell otherwise. I'll share some cases. 64-year-old man, postoperative day 3 from orthopedic surgery. No ischemic symptoms. His troponin is 0.15. The upper limit of normal, again, is 0.04 based on vision, 0.03 is troponin T. This patient has some biphasic anterior T wave changes. This is not clear T wave inversion. It's just biphasic, may represent ischemia, may not, nothing very dramatic. And this patient, has a small troponin elevation, and it's 3 days after the troponin increase, we go to the cath lab. When I ask people, because I can't survey you easily right now, when I ask most people will guess this is a supply-demand mismatch infarct. This shows you the patient's cardiac cath. This is his LAD. You see in the proximal LAD here that there is a stricture and it looks hazy. We can't see thrombus on coronary angiography. We infer it, but you'd wonder whether or not this might be thrombotic in his proximal LAD. This shows you imaging from ocular coherence tomography. So this is showing you the artery and longitudinal section, and this is showing you the proximal LAD. It's already had a dilatation, but this is showing you where that stricture is. And then this shows you the stricture up here in cross section. And what you see is you can see this black ridge all the way around. That's the endothelium. And then you see this white mush in the middle. That is thrombus. This patient who had no symptoms, small elevation of troponin, had a thrombus in their proximal LAD. We then did a large study looking at whether or not preoperative coronary CT angiography could improve risk prediction perioperatively. And what I want to share with you is that in this study, we had 78 patients who had a perioperative MI. If you look at their preoperative coronary CT angiography, just over 30% had either left main or 3-vessel disease. 40%, just over 40% had obstructional coronary artery disease that was not extensive. Just under 25% had coronary disease, but it was not hemodynamically significant. And 4% had normal coronary arteries. If we look at the MINS patients, normal coronary arteries were 7%. The vast majority of patients who will suffer a perioperative myocardial infarction have underlying coronary artery disease, and a lot of them have extensive coronary artery disease. So the pathophysiology of MINS is that data suggests MINS is due to thrombosis in about 20 to 25% of the cases, and supply-demand mismatch in 75 to 80% of cases. Almost all of these patients have underlying coronary artery disease, and this shared pathophysiology has the potential to facilitate identifying effective therapies. We then next would test whether or not dabigatran will be beneficial in treating patients with MINS. We tested dabigatran 110 milligrams twice a day versus placebo in patients who had myocardial injury after non-cardiac surgery. We demonstrated that dabigatran was beneficial. I want to draw your attention to 4 things on the Kaplan-Meier curves. What you see is with dabigatran, what you see first is that in the control group in the first 2 weeks after MINS, 6% of patients will have a recurrent major thrombotic event. What you see is with dabigatran, an immediate divergence of the curves favoring dabigatran. The curves continue to diverge till about a year, and then they remain parallel. But even at 2 years in the placebo group, we haven't seen an obvious plateau of the curves. These event rates are dramatically higher. This is over a 16% event rate. These are dramatically higher than the event rates we see in people that present with STEMIs or NSTEMIs and emerge. Not that I think MINS patients are destined to a worse outcome. It's just that people who present to the emergency room with a STEMI or NSTEMI get very good treatment. Most people with MINS are getting very poor treatment and they're not being followed. They have a way worse outcome. And to drive this home, I want to offer a comparison between the control group in MANAGE and the control group in COMPASS. COMPASS was a large international randomized control trial of over 25,000 patients led out of our research institute, the Population Health Research Institute. And in COMPASS, they were taking patients who had a prior heart attack or had known peripheral arterial disease. And they were managing these patients, and in their control group, which again didn't get an anticoagulation, they had 23 months of follow-up. In MANAGE, we only had 16 months of follow-up. Despite shorter follow-up in MANAGE, where we had patients with MINS, the patients with MINS had a way worse outcome than the patients in COMPASS. So we look at cardiovascular deaths, 7% in MANAGE, 2% in COMPASS. And patients in terms of COMPASS for MI, 2%, in MANAGE, 5%. Again, the patients with MINS are on a very poor trajectory. The problem is most people don't follow the patients and they don't appreciate what happens. We considered the issue of risk estimation. So again, this was the study that we did using preoperative coronary CT angiography to see whether or not this could improve our perioperative risk prediction compared to a clinical model. And so we included just over 950 patients, and we kept the results of the preoperative coronary CT angiography blinded to clinicians and patients unless there was left main disease. We demonstrated was that preoperative coronary CT angiography predicted cardiovascular death and non-fatal MI. It improved it beyond the revised cardiac risk index. It only improved risk prediction for people that had extensive coronary artery disease. The adjusted hazard ratio was 3.76. However, coronary CT angiography in patients who had demonstrated coronary artery disease exaggerated risk in way more patients who would not suffer a perioperative cardiovascular event. The overall impact was that compared to the revised cardiac risk index, preoperative coronary CT angiography resulted in inappropriate risk estimation in 81 of 1,000 patients undergoing non-cardiac surgery, because more patients with coronary artery disease are not going to have an event compared to those that do. We then next turn to whether or not biomarkers can improve risk prediction. And this is a substudy in Vision where we measured preoperative NT-proBNP in over 10,000 patients having non-cardiac surgery. And what we demonstrated is that preoperative NT-proBNP is a dramatic predictor of perioperative cardiovascular events. So if you look at the composite of vascular death or MINS, if your preoperative NT-proBNP is less than 100, your risk is 5%. But if your preoperative NT-proBNP is 1,500 or greater, it's 37%. Even if you look at total mortality, if your preoperative NT-proBNP is less than 100, your probability of death is 0.3%. So, 1 in every 330 patients. But if your preoperative NT-proBNP is 1,500 or greater, your probability of overall mortality is 4%. So 1 in 25 patients. This dramatically differentiates who is at risk of major complications perioperatively. And what we demonstrated importantly with NT-proBNP in contrast to the preoperative coronary CT angiography is that NT-proBNP not only improves risk prediction amongst people that were going to have events, it improves risk prediction in people that would not have events. So this as a marker is way more helpful compared to the imaging data. I next want to move to an area that we've had a lot of focus on of perioperative overt and covert stroke. So if we look at the incidence of perioperative overt stroke, so from Vision, what we see is that 0.33% of patients will have a perioperative overt stroke. This has an important implication that it does increase your risk of perioperative death, but it accounts for very few deaths because perioperative stroke, overt stroke, is very uncommon. But again, if you get it, it has devastating effects, both either death or being left incapacitated. In POISE-1, 30% mortality, 32% mortality in people that have stroke, and 59% needing help with their activities or incapacitated. Based on this finding, this made me wonder, perhaps similar to the issue of myocardial infarction, is it possible that in fact there is more strokes happening perioperatively similar to MI and myocardial ischemia? And so what we did was we did the NeuroVision study. What we did was we took just over 1,100 patients age 65 or greater having an elective major non-cardiac surgery. And we did a brain MRI with diffusion wave imaging between day 2 and 9 after surgery. We had 12 centers in 9 countries participate. 78 patients, that is 7%, demonstrated a covert stroke, a covert infarct on their brain MRI. That is, there was no stroke identified clinically, but when we did the brain MRI, 7% of people had a covert stroke. Importantly, the incident was consistent across all the centers, all regions of the world, all forms of non-cardiac surgery, even including low-risk surgery. And this just shows you a patient who has individual strokes, but also to make the point, there was some patients, 13% of the patients had multiple covert strokes. We also demonstrated that our primary endpoint of cognitive decline was increased essentially twofold in the people that had the perioperative covert strokes. Again, these events were not benign. It doubled the risk of cognitive decline 1 year after surgery. That went up to 42% in the people with the covert stroke group. We also demonstrated that it doubled the risk of perioperative delirium if you had a covert stroke. And if you had a covert stroke, there was a 4-fold increase in the following year. You would go on to an overt stroke or a TIA compared to patients with a no covert stroke, identifying that this is a big problem, but importantly, this may be a modifiable problem, which we're now testing in other studies. I now want to move to the issue of timing of surgery. So I'll talk first about the HIP-ATTACK 1 trial, which we published in The Lancet a few years ago. The impetus for this trial was 10 years ago, I was consulted to manage a 73-year-old lady who had a hip fracture and an elevated troponin. The referring physician who called me, I was on in the CCU, indicated that the patient's heart issue had to be treated before they could do the hip fracture surgery. Despite the best of intentions, the patient ended up getting some antiplatelet therapy. The patient would end up bleeding. They would die. They would never make it to the OR for their hip fracture. This made me wonder if the current approach of medical optimization of patients with hip fractures is really in their best interest. And maybe, in fact, patients would be better off if we just did surgery very fast and we removed the stimulus that drove the cardiac ischemia in this case. So then we undertook the Hip Attack 1 trial. We randomized just under 3,000 patients who were age 45 or greater, diagnosed with a low energy mechanism hip fracture that required surgery. We had 69 centers in 17 countries. Patients were randomized to accelerated surgery with a goal of surgery within 6 hours of the hip fracture, or to the standard timing of surgery, which ended up being 24 hours. Among patients with a hip fracture, accelerated surgery did not significantly lower overall mortality or a composite of major complications, but also accelerated surgery demonstrated no evidence of harm, even in people who demonstrated acute medical instability at presentation, including patients with elevated troponin. What accelerated surgery did demonstrate was that it lowered the risk of delirium, it lowered the risk of urinary tract infections, it lowered the risk of moderate severe pain. It also allowed patients to stand faster, mobilize faster, and to do full weight bearing faster. And it resulted in patients going home about a day and a half sooner compared to the standard care group. We also demonstrated that in the subgroup, which was related to why we did the trial in the first place, people with elevated troponins on presentation, if patients had an elevated troponin on presentation, the accelerated care group had a really large benefit in terms of overall mortality, a hazard ratio of 0.38. Flavia Borges in our group, and Francesca, when she was here, was the project officer on this, are leading Hip Attack 2, which is randomizing patients with an elevated troponin and a hip fracture to accelerated surgery or standard care, looking to see whether or not this subgroup effect is true, that there's a mortality advantage. I finally want to switch to the area of virtual care and remote automated monitoring technology. We've done a bunch of studies. I will show one and highlight some important points. So the PVCRAM-1 trial was a randomized controlled trial of patients age 40 or greater being discharged after non-elective surgery. We did this during COVID. We had just over 900 patients, half randomized at discharge to go home with virtual care and remote automated monitoring technology, RAM, or just to go home with normal follow-up. We had 8 centers in Canada that participated in the study. If the patient was in the virtual care with RAM group, they went home with a tablet and RAM technology. The RAM technology allowed us to measure the patient's blood pressure, heart rate, respiratory rate, oxygen saturation, temperature, and daily weights for 30 days. Patients also filled out a recovery survey for us daily. The virtual nurses interacted with the patients daily from day 1 to 15 and every other day, day 16 to 30. We did wound photos day 1 to 15 and every other day, day 16 to 30. Importantly, we set thresholds for which we wanted the nurses to have to escalate care to the perioperative care physician for the blood pressure, heart rate, oxygen saturation, respiratory rate. But centers were allowed to change the thresholds on individual patients or in the overall cohort. This is the technology. So basically, patients will put on the blood pressure cuff, they press that button. It automatically measures the blood pressure. It is Bluetooth to the tablet. The tablet is cellular enabled, and we get the results instantly. Same for heart rate, temperature, etc. Overall, if we look at acute hospital care, that is ER visit or readmission to the hospital, 22% of patients in the virtual care group, 27% in the standard care group, and this is during COVID. 5% absolute difference, a result that just missed being statistically significant, but there's much more to the story. Brief acute hospital care, same pattern. Hospital admissions, 13% of people in the standard care group were readmitted to the hospital in a 30-day period, 10% in the virtual care group, and ED visits, 24% and 20%. If we look at detection of medication errors, 30% of patients in the virtual care group had a detected drug error, only 6% in the standard care group. Correction of the drug errors, exact same pattern, a 24% absolute benefit in the virtual care group of correcting drug errors. Pain at 7 days, 15 days, and 30 days, 14%, 12%, 10% absolute benefits in decreasing pain and also decreasing moderate to severe pain. We demonstrated in the study that the reality was centers changed the thresholds for which nurses would escalate care to physicians. There ended up being 3 centers, which were high escalation centers, where 89% of patients had their care escalated to a physician from the nurse. Intermediate centers where only 55% had their care escalated, and low escalation centers too, where 34%. But the story is even bigger than that, because it's not just the percentage of patients, it's the number of escalations. In the high escalation centers, 758 escalations, intermediate 227, low 56. Importantly, if you look at the high escalation centers, you see change in medication occurred 237 times, only occurred 124 times in the intermediate, and only 24 times in the low. And if you look at virtual visits with a physician, exact same pattern. Then what you see is, if you look at acute hospital care, that is ER visit or readmission, you have a 45% reduction in the high escalation centers with virtual care and RAM compared to standard care. No effect in the intermediate and low escalation. Exact same pattern for brief acute hospital care. Big benefit in the high escalation centers with over a 50% reduction. ER visits, exact same pattern, big effect in the centers that are following the protocol. And hospital readmission, exact same pattern. Insights from PVCRAM1, we see high rates of acute hospital care after hospital discharge post-surgery, even during COVID-19, 27% in the standard care group. High rates of drug errors, 30% of drug errors, and on average, these people had 2 drug errors. High rates of pain, and even high rates of moderate severe pain. Virtual care with RAM increased identification and correction of drug errors and reduced pain. And in centers with high escalation and management of care, 40 to 50% relative risk reduction in acute hospital care, brief acute hospital care, and ER visits. Crucially, it is only credible to expect virtual care with RAM to impact outcomes if it identifies the problems and it changes care. You can have the world's greatest technology. If no one changes care, you will not change the outcomes. And this has been one of the problems that has existed in the area of virtual care with RAM technology. People assume the great technology will identify a problem and someone will automatically correct it. That does not always happen. Future, SPIRE-AF trial we're currently doing. David Cohn in our group is leading it. It's a trial of patients who get periop or atrial fibrillation. They're randomized to either anticoagulation with a DOAC versus no anticoagulation. 2,800 patients in this trial. HIP-ATTACK-2, which Flavia Borges in our group is leading. Again, patients with myocardial injury and a hip fracture randomized to accelerated surgery versus standard care. The PREVENT trial has just now been finished. Wojtek Szczeslik led us, 2,000 patients, non-cardiac surgery randomized to ivermectin versus placebo as a potential way to also control the sympathetic system. Vision 2, we're just getting ready to start. 20,000 patients having non-cardiac surgery will wear continuous non-invasive hemodynamic monitoring that will give us continuous blood pressure, continuous heart rate, 5-lead ECG, temperature, respiratory rate, oxygen saturation, body position, movements, and even sleep analyses for 30 days after surgery. And what we will do is we will then look to see what are the patterns that identify 9 hours from now, 6 hours from now, a clinical diagnosis of sepsis or myocardial injury or bleeding, etc. In PVCRAM2, we just finished PVCRAM3. There was a change in the order of it, but which I'm very excited about the results using the virtual care with RAM. And then PVCRAM2 has just started, where we're randomizing patients, 2,500 patients again, to virtual care with RAM after surgery. I just want to highlight a few people in our group. This is Dr. Richard Whitlock, who is a cardiovascular surgeon who leads lots of really important trials in our purpose setting. He led the LAOS-3 trial that showed left atrial appendage occlusion in people having cardiac surgery with atrial fibrillation reduces the risk of stroke. Andre Lammy's another one of our cardiac surgeons, led big trials on pump, off pump, and several other trials. David Cohn is leading the ASPIRE trial that I just mentioned. He also led a big trial in anti-inflammatories perioperatively. Mike McGillian is my cohort who works very closely with in terms of the virtual care remote automated monitoring technology. Sandra Forey leads our big smoking perioperative trials program. Emily Bellicote leads a big program in cardiac surgery, postoperative care, lots of trials on anticoagulation and other interventions. Flavia Borges leads a number of things in our program, but a lot of things that deal with system change, like the HIP-ATTACK trials. Jessica Spence leads big trials in terms of cardiac surgery and system approaches to this, and Bill McIntyre leads our cardiac surgery atrial fibrillation research program. Heather Gills, my assistant, makes all this happen. Jessica, Vincent, and Valerie Harvey are also key staff at our PHRI that make this happen. Also, too, we have a division of perioperative care, and there's people who make this work. So Rahima Nenshi is one of our surgeons. Vikas Tannen runs our fellowship program. We have a lot of people come that train with us in perioperative care program for a year. And Amin Patel also leads one of our sites. This is my wife who keeps me on track, our daughter Olivia, and our dog Katara, and our son Nathan. And so, in conclusion, it takes a community to inspire, mentor, and enable a successful academic physician. Although surgery can improve and prolong patients' quality and duration of life, it's associated with cardiovascular complications. Our work is informed prediction, identification, prevention, and management. The future is very promising, and I hope that all of the bright young folks in the group will pursue careers in perioperative research. There's lots to happen. Thanks very much.
Thank you really very much. This has been really an inspiring presentation. Congratulations, really, really amazing. Thank you. So I will give the word to Francesca Mulazzani, who will manage the questions that arrived during the webinar. Thank you again.
Yeah, thank you, Thomas, and well, thank you, Dr. Devereaux, always, yeah, very inspiring to me as well. So we collected some questions. First of all, I think that sometimes the most, how can I say, interesting topic, especially for us as anesthesiologists that try to follow patients in the perioperative care, is about the myocardial injury after non-cardiac surgery. So regarding this, one question was, how do you manage patients at increased risk of MINS in your clinical practice, and how are they managed in the post-operative care? Are they monitored for how many days or hours in the ICU or also in the high dependency unit? And as well, if the troponin monitoring is followed by electrocardiogram as well.
Yeah, so in our hospital, we have a perioperative care service, and we have 3 services that run simultaneously. There's one that deals with the inpatient service, which helps to co-manage higher risk patients with the surgeons or anyone that gets complications. So if we saw anyone pre-op, we will automatically help co-manage them post-op. There's another service that does our surgical transition program and research around the virtual care with remote monitoring technology. So when people are leaving the hospital, we send them home with the tablets and monitoring technology. So there's one service running that. And there's another service that does our clinics, both pre-op and post-op follow-up clinics. Any patients that are coming that are identified in our service pre-op that are at high risk for MINS, the first thing is we will try to optimize them prior to surgery. We will identify who is at risk and then who should have troponins measured post-op. And our service will follow along with all those patients automatically. So many of the things I talked about that we try to make sure happen with the management of aspirin, antihypertensives, tranexamic acid will automatically happen with our patient population. But importantly is that making sure that you measure the troponins post-operatively. If patients then have, we don't automatically do ECGs. It's only if the troponin is elevated, we will then do ECGs. But if patients then have an elevated troponin and end up meeting the definition of MINS, those patients, unless they've had some real bleed, are going to be put on aspirin, a statin, and an ACE inhibitor. And then in the coming days, we will look to put the patient on dabigatran. We have a number of studies going on where we will then do further risk stratification. Right now, we're doing cardiac PET studies, but we're also doing stuff with cardiac CT angiography, because there are a number of patients that do have very extensive disease that will benefit from revascularization. So that's how we manage these patients.
Okay, yeah, because I think one other question was about when do you recommend coronary CT angiography in some of these patients?
Yeah. So one thing I can tell you, because of the studies we've done with even acute angiography, as cardiologists, if we take people to the cath lab and there's a lesion, it's almost for certain it's going to get intervened upon. The patient's going to get a stent and now is committed to dual antiplatelet therapy. Because patients are close to the time post-surgery, we've had some patients in our studies who have now got a fresh stent on dual antiplatelet therapy and then bleed. and then we have to withdraw the antiplatelet therapy. We've had some get in-stent thrombosis. Individual cases never tell you how to manage the right way to manage all patients, but they tell you what's possible. As a result of that, our current approach is that we will only send patients to angiography who have MINS acutely if they demonstrate ST elevation or they demonstrate recurrent ischemic injury. So they start getting chest pain, or they get into heart failure, or they had a serious arrhythmia, VT or something. Then those patients we would send to the cath lab. Otherwise, we manage them medically, and then we will get these rapid tests done, even as an outpatient primarily. And then if there's high-risk features on these non-invasive tests, then we will send them to the cath lab. We do hope to do a trial where we'll randomize people to an invasive versus non-invasive strategy, but it's riskier than just general cardiology because you're very proximal to surgery. So I think we do more patients benefit if in fact we manage it medically and then only go to acutely the cath lab if there's instability, and then follow them up with non-invasive tests and then send people to cath lab if they show very high risk features on the non-invasive tests. The one other group that we give consideration to earlier cath is people who have the troponins over 1,000. So if you have a high sensitive assay that's over 1,000, that patient is at substantial risk of a very bad outcome. So it's another patient who, depending on other things, we may end up going earlier to cath versus not. But a minority of people will go to coronary angiography during their acute stay with us. But we typically will end up getting the cardiac PET or CT angiography within 2 weeks of the event.
Okay. So just stepping over to another topic and question was about all the focus of your research are focused on cardiovascular complications and maybe neurological complication like stroke. So we were thinking, do you think you will move, or maybe there could be space for also pulmonary complication in the future, like that probably we are more sensitive about it?
Yeah, so I want to be clear, like, even though I am dominantly focused on vascular complications, I want to have no ambiguity that sepsis, as an example, is the other big driver of death. And you could have sepsis through pneumonia, but sepsis is the other big driver of death. There's other things that are very important. There's people in our group who lead programs on that. And as an example, a big focus in Vision 2 is to actually understand, we expect probably 700 cases of sepsis in Vision 2. And we will be using artificial intelligence to be monitoring continuous blood pressure, heart rate, oxygen saturation, temperature, all these variables, respiratory rate. And what we hope to be able to do is identify the footprint that tells you 9 hours before the clinical diagnosis of sepsis that this is a very high probability sepsis will be diagnosed. If we can get to that and understand that pattern, then we will randomize people to that technology or not to that technology in the future, and we'll offer early alerts that this is a pattern highly suggestive of sepsis 6 or 9 hours from now. And we hope we can get to a place post-operatively where we intervene on early infection and we never see sepsis. But I just do want to be clear, yes, the vascular issues matter, but they're not the full picture. The infectious issues matter, respiratory issues matter, but within these respiratory issues, pneumonia is the dominant one that matters in terms of impact on mortality. But it's a very important event, and there's definitely people in our group that have a focus on that. And within Vision 2, that is a big focus that we really understand how to get to much earlier diagnoses so that we intervene when the problem is small, so we don't get to the big problems.
Okay. There is also another question about the timing to surgery, because I think it's a very fascinating approach and topic. Which do you think could be the balance between diagnostic exam performed before surgery to identify and stratify the risk and try to optimize the patient, and in some cases, for example, hip fracture patients, try to reach surgery as soon as possible to maybe, as we know, reduce the stress or try to reduce the risk to develop complications?
Yeah. I mean, obviously, I think it's important that we see what the results of HIPAA 2 show, but what I would put forward even at this point, so as an example, because in our program of doing the HIPAA trials, at first when we were doing them, if a patient had an elevated troponin, the surgeons and anesthetists were very uncomfortable about doing surgery right away. But because they were in the trial and people then did surgery right away, what would happen is people would have, I've even seen people with troponins like of 1500 go right into the OR. And almost in the vast majority of cases, what you see is the troponin level is immediately down after surgery. That doesn't mean that it's the right approach, and it doesn't mean that there's no patient who might be harmed with that approach. But it definitely tells you that there's a lot of patients where, in fact, the physiological stress of the fracture drives the myocardial ischemia. And when you remove the physiological stress of the fracture, people actually are doing better. In HIPAA 1, patients who had medical instability on presentation, they did not demonstrate any harm from accelerated surgery. For certain, if I had a hip fracture or my mother or father had a hip fracture, I would definitely want accelerated surgery. I think that there's very few things for which we benefit in delaying the surgery. But that, again, I'm not suggesting that there can be anything that you'd want to delay for. You should always assess each case. But I just do put forward that most of the things that people get their surgery delayed for, they're not things that we couldn't start treatment on and go to the OR. It's much easier to manage people medically on the other side of the OR. And, so I think, again, HIPAA 2, I think, will be a really important contribution. But so far in all the research we've done, we've also done some work in acute cholecystitis with accelerated surgery. So far in the research we've done, we don't see any harm with accelerated surgery, even in people who are somewhat unstable. And my own feeling is most people that are unstable don't do well because of the physiological stress of the underlying condition that surgery would address. So in most situations, I think if you're going to go to surgery, you're probably better off to go sooner as opposed to later. But again, further HIPAA 2, other studies will continue to enhance our understanding of this.
Okay, so I think we have one last broad question that probably will involve us also as a specialty of physician, which is which maybe could be the role, how do you envision the role of anesthesiologist in the framework of perioperative medicine, and also how is the collaboration and which is the role of anesthesiologists and perioperative physicians in Canada? That maybe could be interesting for us.
Yeah, so I published an article in New England Journal of Medicine about 2.5 years ago that was a debate on who should manage it was focused on hip fracture patients, but I get into who should definitely manage the patients. I made the case at the end that what the future should be, I believe, is that ideally we need perioperative care services. And ideally those services would be made up of some people who come from anesthesia, some people who come from medicine, and some people who come from surgery. In North America, our critical care ICU departments have people from anesthesia, medicine, and surgery. And I believe that it's made our critical care setting stronger because every one of those groups not only bring expertise that they train in critical care, but they also bring expertise from what they do the majority of their clinical time with being at anesthesia, surgery, or medicine. And I believe the same is true in perioperative care, that I think we would be a lot stronger if we actually developed services which have some weeks being covered by people in medicine, some weeks being covered by people in anesthesia, some weeks being covered by people in surgery, but those people are going to dedicate, let's say, 15-20% of their clinical time to doing perioperative care. My general observation, so as an example, just because someone's a cardiologist, I don't think that makes them good at managing perioperative myocardial ischemia. And the reason is that unless you see a lot of patients in the surgical setting and you manage them, I've told you cases where, in fact, I've managed people based upon my general cardiology, experience that was the wrong approach that led to even us doing the hip attack trials. You want people who are going to spend time in these areas because that's what makes for better physicians. I really think that it would be unfortunate if anesthesia or medicine or surgery were the only people doing that. The service will be stronger if all those disciplines come together and help to build it. Moreover, we really have to develop surgical transition teams where we're going to send, and I would advocate more and more people home with virtual care and remote monitoring technology. There is nothing I've done in my career of managing people with acute heart attacks, heart failure, or perioperative care. There's nothing I've ever done where I get more feedback from patients voluntarily regarding our virtual care surgical transition program. So on that service, there's typically 80 patients a week that'll be on that service that you're managing, and let's say 20 maybe being signed off. 5 to 6 frequently spontaneously when you're signing them off after they've finished 2 weeks or whatever it is, their follow-up, will just say how incredibly, grateful they are and how that was so different than anything they had before, especially if they had prior surgery their loved one did. Because you can imagine, like a lot of our patients, most people having major surgery are older. They're going home. They're frequently on a lot of drugs before surgery. Some of the drugs are altered. Some drugs have been added, dose changed. Then they're sent home. As I showed you, 30% of people have drug errors. There's endless confusion. Plus, they go home. They've been told 100 things, and they're not sure what to do. So that support, just is such a different experience. Also, the other thing that you can do if you do these surgical transition programs is that a failure, I believe, of perioperative care has been everyone is focused on making sure people survive the perioperative period, which clearly we want to make sure people survive. But what we fail to do is to actually make sure people are on the right therapy for long-term health. There's all kinds of patients who come to surgery who have known atherosclerotic disease, who are not on a statin, not on an antiplatelet, not on an ACE inhibitor, still smoke. And for the most part, people aren't addressing that. Now, understandably, in the acute perioperative period, it's hard to address it because of all the competing physiological issues that exist in the acute care. But with these surgical transitions, you have much greater potential for care. So I really hope that we're going to see a future where there are perioperative care services where we have anesthesia playing a major role, we have some people in medicine playing a major role, and some people in surgery playing a major role, and that we really move forward with developing these types of programs. That's what I think will really bring people forward. There is no doubt we can make more advances in the OR, but the reality is what is wrong with surgical care is not the OR. The reality is the safest period is the OR, even though it should be the highest risk period. It is the safest period. If you look at mortality, almost no one dies in an OR, even though families are anxiously waiting for the surgeon and the anesthetists to show up and tell them if their loved one's alive. They really should show up the next day and ask if their loved one's alive. The OR is the safest period, and yet that was not the case 100 years ago. It was the highest risk period 100 years ago. But then you folks, anesthetists, then became the primary person responsible for the patient's physiological stability in the OR, and you brought monitoring technology. And now OR is incredibly safe. But the problem is when people leave, obviously a trivial number go to the critical care. Most people go to the surgical floor, and more people are being pushed home sooner. And if we really want to advance and improve the safety of surgery, we have to address postoperative care. I believe anesthesia should play a critical role in this, but I understand that not everyone in anesthesia is going to be interested. That same is true that not everyone in anesthesia is interested in chronic pain. But I'm hoping that there's some people in anesthesia that are really interested in this, same in medicine, same in surgery, and that we really develop that, because that's where the problem is. The problem is in postoperative care. And postoperative care also gives the ability not only to better manage, identify early and better manage complications, but to also make sure we get people on the right treatment for long-term health. And that's what I think is the future.
Thank you.
Thank you really so much. This has been really inspiring, and really, we have a lot to think about, and about our practice, and how also we do research. So thank you again very much. And thank you everybody for listening to this excellent webinar. With this, I close the webinar, and I am glad to tell you that we have already programmed the next webinar, which we held on the 12th of June at 4 p.m. with Professor Mette Berger from the University of Lausanne, who will talk about metabolism and nutrition in the critical ill patients. So thank you again to Professor Devereaux, to everybody, to Francesca, Stefano, Professor Fumagalli, and I wish you a very nice day. Talk to you soon.
Thank you so much.
Thank
Bye-bye.
you.